We have a 57-year-old white male with past medical history of hypertension presenting to the ED with bilateral lower extremity edema and shortness of breath that has recently worsened. Workup in the ED revealed elevated blood pressure, chest x-ray with pulmonary edema, creatinine elevated at 4.0, troponin 0.17, and repeat troponin 0.12. EKG was sinus tachycardia at 118 beats per minute, and BNP was greater than 5,000. He was given Lasix 80 milligrams IV and started on a nitro drip for blood pressure control. The patient seen at bedside this morning reported that his breathing was significantly better since admission. He states he had been diagnosed with hypertension in the past, but over the past year he had not taken any of his home blood pressure medications. He denies any chest pain, pressure, tightness, denies shortness of breath at this time, denies palpitations, dizziness, lightheadedness, orthopnea, or paroxysmal nocturnal dyspnea. Other past medical history includes an appendectomy years ago, but that's about it. Family history, hypertension, and type 2 diabetes. He endorses alcohol use on the weekends, a couple drinks. Denies recreational drug use and has never smoked. He has no known drug allergies and on no other home medications. Vitals, we had temperature 36.8, pulse 80 beats per minute, blood pressure 165 over 112, respiration rate 18, pulse ox 88 on room air. Patient is ANO times 4 and no acute distress, atraumatic normocephalic head, extraocular eye motions or eye muscles intact, JVD was present, no carotid bruise, regular rate and rhythm, normal heart sounds and no murmur. Decreased breath sounds bilaterally with some rails present. Abdomen was soft, non-tender, normal vowel sounds, and he had 2+ bilateral lower extremity pitting edema. His skin was dry with normal color and temperature. Differential diagnosis includes acute decompensated heart failure, hypertension, hypertensive crisis, acute coronary syndrome, acute renal failure, type 2 diabetes, alcohol-induced cardiomyopathy, atrial fibrillation, and pulmonary embolism. We already got some of the diagnostic studies such as BNP, EKG, troponin, CMP, CBC, X-ray, etc. Other things we want to do is order the echocardiogram, continue to trend his troponins, electrolytes, and creatinine, as well as monitoring his blood pressure. Before discharge, a dry BNP should also be performed to see the patient's baseline BNP. On echo, the patient was found to have a mild to moderately dilated LV with ejection fraction 15 to 20%, global hypokinesis, and grade 2 diastolic dysfunction. So the treatment plan. All of these findings lead us to acute systolic heart failure. As shown, the echo has a reduced ejection fraction. Chest x-ray shows pulmonary edema and cardiomegaly, and the BNP is greater than 5,000. And this is likely due to uncontrolled hypertension, as the patient has not been taking his blood pressure medications for over a year. The plan is to continue GDMT with beta blockers, hydralazine, isosorbide dinitrate, and along with the Lasix, but we have to avoid an ACE inhibitor, an ARB, or ARNI because of his current renal function. We also consider adding the ARNI or Entresto after fluid status optimizes with the loop diuretic. So we're going to continue Lasix 80 milligrams IV every 8 hours and continue to monitor his renal function and electrolytes. Also, we need to be monitoring his fluid intake and outtake as he is in heart failure. The patient's increased troponin could likely be due to underlying ischemic heart disease, or it could be due to his AKI. Since troponin is only mildly elevated, we will continue to trend it, but thus far the trends are not concerning for an acute MI. An outpatient cardiac stress test could be considered following discharge. For the patient's hypertension, we already got him off the nitro drip as his BP wasn't really improving. The systolic blood pressure was remaining in the 180s, so we plan to increase his hydralazine to 50 milligrams PO TID, continue carvedilol, isosorbide dinitrate, and we started amlodipine. For acute renal failure, we're going to continue to trend the creatinine, and nephrology is already following. Since this patient is not stable, we need to continue monitoring a lot of these parameters and labs we already talked about, and he needs to remain in the ICU or a step-down unit. Upon discharge, he needs to see cardiology within a week. All right, and then patient education. So we got some tests back, and it looks like your shortness of breath and your leg swelling is likely due to something we call systolic heart failure. And this is when your heart becomes too weak and it's not able to pump the blood as well to the rest of your body, leading to a backup in the lungs and in the rest of your body, like a backup being your lungs are congested, not able to breathe, and your legs are congested. The blood's not able to get back up, the blood's pooling down in your legs. So this is likely because of your high blood pressure that you've had for a while. And when you have this high pressure, it can cause your heart structure and function to change, making the muscles not work as well as they're supposed to. So your echo did show your heart is not contracting as well as it should, and your x-ray did show the fluid buildup in your lungs that we just talked about. So to get this under control, we have to get your blood pressure down and get some of that fluid off you. The Lasix that we've been giving you is helping pull some of the fluid off your body, which you said it feels like you're breathing better. That's likely why. For systolic heart failure, we use something called GDMT that has been shown to decrease mortality in your condition. This includes an ACE inhibitor, an ARB, a beta blocker, and these control your blood pressure, but however, with your declining kidney function, we don't want to give you the ACE or ARB just yet, because those can worsen your kidney function. And then you're on the beta blocker, hydralazine, and isosorbitol that help with decreasing your blood pressure and treating the heart failure. So at this time, we need to continue to monitor your heart and your kidney before we can talk about you going home. But it's super important when you get home to stick to the medication regimen that we give you or that another cardiologist gives you, to make sure that your heart function isn't getting even worse and you get these reoccurring symptoms of trouble breathing or swelling. And then it's also important to make sure you make some lifestyle modifications such as eating healthier and staying active, which have been shown to help with blood pressure and heart failure as well.